So, coming to the pathophysiology of portal hypertension. In the cirrhotic patients and the non-cirrhotic patients, the causes of portal hypertension is usually because of the changes that occurs within the portal resistance and within the changes of the portal flow. So if there is an increase in the portal resistance and in combination with an increase in the portal flow, this causes the increase in the pressure within the portal system, and this causes portal hypertension. So, if we talk about the hemodynamic principles of portal hypertension, so this is a vascular distribution of the portal hypertension, and there are different sites of action of the portal pressure and the drugs that we are going to be giving. So, first of all, if we talk about the circulation, we've got the hepatic circulation, we've got the collateral circulation, and the splenic circulation. So, in the hepatic circulation, it usually occurs, what happens is that the portal flow is occurring, and what happens is that there is a decrease in the nitric oxide. So the decrease in the nitric oxide is mediated, and then there's an increase in the endothelin production. So ultimately what happens is that there is vasoconstriction of this hepatic circulation. Now, if we talk about the splenic circulation, a complete opposite sort of events happens in this circulation. In the splenic circulation, what happens? There is an increase in the nitric oxide, which causes the vasodilation of these vessels. And then coming lastly to the collateral circulation, what happens is that because of angiogenesis and because of the dilation of the blood vessels within this, there is a compensation of the events that are happening within the portal system. So in compensation, what happens is that this collateral circulation, it tries to decompress whatever resistance, whatever hypertension is going on within the portal system, and it tries to compress it, tries to compensate it, but it is not done fully. It's very inadequate. So what happens is that there is a dilation of the blood vessels within the collateral system, which ultimately gives rise to the esophageal varices and then the bleeding within the esophageal varices. So, if we talk about the drugs that we can give to our patients in response to these different circulations, if we talk about the heart, we can give beta adrenergic blocking agents. And then we've got the varices happening, the esophageal varices. The ultimate treatment is the ligation and the sclerotherapy. And then if we want to have a complete surgical treatment of the portal hypertension, there is the surgical and transjugular intrahepatic shunts that helps in compensating the hypertension. And then to control the vasoconstriction that is happening within the hepatic circulation, we can give nitrates, we can give ARBs, and then we can give prazosin. And if we want to control the vasodilation that is occurring within the collateral circulation, the drugs that we can offer is the beta adrenergic blocking agents and the angiogenesis inhibitors. Angiogenesis occurs, which is the formation of new vessels within these collateral circulation. So we need inhibitors for that. And then lastly, to control the splenic vasodilation, we need somatostatin analogs, vasopressin analogs, beta adrenergic blocking agents, and nitrates have proven to show some results. So coming to the representative vasodilator and vasoconstrictor molecules. So there are a list of molecules within the vasodilation category and the vasoconstriction category. So these are all implicated in the formation of the portal hypertension. So if we talk about vasodilators, what are the molecules that are causing vasodilation? It could be because of adenosine, serotonin, it could be carbon dioxide, nitric oxide, it could be prostacyclin. endothelium derived molecules, and then lastly hyperpolarizing factors. So these are all the molecules that causes the vasodilation. And then if we talk about the vasoconstriction, it could be because of norepinephrine, serotonin, and lastly because of endothelin 1 angiotensin, and then leukotrienes and thromboxans. So what usually happens is that, so there's an equilibrium. If there's an equilibrium between both of these categories, so we wouldn't have any problem. But the problem occurs when there is an increased vasodilation and a decreased vasoconstriction. So, like I've mentioned before in the previous slide, that when there's an increased vasodilation that is occurring, it is because of the splanchnic circulation that is being harmed. So, vasodilators are increased and the vasoconstriction are decreased. This causes the splanchnic circulation to be disturbed. And then the complete opposite, if there is an increase in the vasoconstriction, and there is a decrease in the vasodilators equilibrium. So this causes the intrahepatic circulation to be at loss. So it causes the vasoconstriction. So in combine, the vasodilators of splanchnic and the vasoconstriction of the intrahepatic arteries, this in combination, it causes the portal hypertension. So now if we talk about step by step reasons and causes of the portal hypertension, we'll be talking about that in detail. So we've got the liver, we've got the cirrhotic liver, and then we'll be talking what are the changes that are occurring within the splanchnic circulation and then the systemic circulation. So in the cirrhotic liver, what happens is that the sinusoidal endothelial cells are completely destroyed and there is a dysfunction. Like I mentioned before, that the important thing is that there should be fenestrations. So fenestrations are at loss and then it causes a complete dysfunction of the endothelial cells within the sinusoids. And then we've got the hepatic stellate cells that are activated, and it causes the formation of collagen and then fibrosis and inflammation. And then we've got the Kupffer cell activation. So next what happens is that this causes a reduced nitric oxide bioavailability. Like I've mentioned, a reduced nitric oxide, it causes vasoconstriction within the liver, within the capillaries and the arteries of the liver. So this causes a defective response to vasodilators. Obviously, there is vasoconstriction going on and vasodilators are not responding. And then we've got the increased production and excess response to the vasoconstrictors. So vasoconstrictors keep on going. And then ultimately, we've got the increased hepatic vascular tone. Because of the vasoconstriction, there's an increased resistance within the liver, and increased resistance, increased blood flow, and this ultimately in combination, it causes portal hypertension and it causes the increased hepatic vascular tone. There could be because of some architectural disturbance within the liver. And so this increased hepatic vascular tone ultimately causes the formation of portal hypertension. So portal hypertension, if we talk about the splanchnic circulation, it could be because of the increased production of vasodilators. Like I mentioned in the previous slide, in splanchnic circulation, we have the vasodilation that is going on. So increased vasodilation, defective response to vasoconstrictors. Vasoconstrictors are trying to constrict the blood vessels, but they aren't responding. And then we've got angiogenesis, that is the formation of new blood vessels. And then if we talk about the systemic circulation, we've got the splanchnic arteriolar vasodilation. And then there's an increase in the collateral blood flow. The systemic circulation, also known as the collateral circulation, like we mentioned before, there is a vasodilation that is occurring within these blood vessels too. And then the portal collateral blood flow, it also contributes in the formation of portal hypertension. And then if we've got a arteriolar vasodilation, it causes a decreased effective blood volume and hypotension occurs. And then we've got the activation of the neurohumoral factors, and then the increase in the sodium and water retention. So sodium and water is retained within the body, and there's a very decreased output of this outside the body, and it causes hypovolemia. And then ultimately we've got the increased cardiac output. So this ultimately causes a whole scenario for the portal hypertension. Activation of neurohumoral factors also contributes into the increased hepatic vascular tone. So intrahepatic vascular resistance, it also causes because of the architectural disturbance. So this in combination, it ultimately gives rise to portal hypertension. And then if we talk about the splenic circulation, the vasodilation within the blood vessels, and then the systemic circulation, which ultimately causes cardiac output, which is increased. So what happens is that it aggravates this syndrome as a whole. The splenic and the collateral circulation, it completely worsens the situation of the portal hypertension.